Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
Welcome back to the Dusty Muffins. I'm Christine, and today we're talking about heart health, but not the surface level, your cholesterol is fine, see you next year version. February is American Heart Month, and this episode is about the risks that don't always show up on routine labs, especially as we move into midlife.
Exactly. This is for women and all people who've been reassured by normal numbers, but still feel uneasy because sometimes the standard tests don't tell the full story.
And if you got family history, early cardiac events around you, or just a sense that something deeper might be going on, then this conversation is for you.
We're thrilled to welcome Dr. Sunny Intwala, a leading preventative cardiologist with Nuvance Health, part of Northwell Health, caring for patients throughout the Hudson Valley in New York. Dr. Intwala trained at Brown University, earned his MBA from Columbia Business School, and cares for thousands of patients each year, focusing on cholesterol management, cardiac imaging, and heart disease prevention.
Which is exactly why we wanted you here, because prevention means asking better questions earlier.
And today we're digging into ApoB, Lp(a), imaging, sex differences, menopause, and how to understand heart risk without panic. So, Dr. Intwala, welcome to the Dusty Muffins. Thanks for joining us.
Thank you for having me. Excited to be here.
Yeah, great to have you here. Let's start where most people begin, with our standard lipid panel. We have a total cholesterol, LDL, HDL, triglycerides, and if those numbers look good, people are usually told they're in the clear. But from your perspective, is a standard lipid panel really enough to assess cardiovascular risk?
That's a great question. When we take a look at the standard lipid panel, it tells us, maybe from 40,000 feet away where we are within someone's journey into developing cardiovascular disease. One of the particles that I've been measuring in all my patients now at least once is lipoprotein A. It's a cholesterol particle that most standard blood tests don't measure. It's genetically determined. It behaves very differently from regular, or the bad cholesterol or LDL, so to speak. And so, I think of, our blood vessels like almost like a highway of things floating through it, right? You have blood vessels that go to your heart, they go to the blood vessels that supply your legs, and you have bad cholesterol that's floating around. And oftentimes, I give this analogy to my patients. You have bad cholesterol that floats around, and LDL, which is your bad cholesterol, I think of that as a rubber ball. So sometimes that ball hits the artery wall hard, but it kind of bounces back. However, when you have Lp(a), that's essentially a bad cholesterol particle, but covered in Velcro. And so that essentially sticks to the arteries. And so that causes inflammation and it promotes clotting. That stickiness is why Lpa is so dangerous and why most people with normal cholesterol can still have heart attacks. So to answer your question, yes, the cholesterol profile is great. You get excellent metrics from it. I really focus on LDL cholesterol, which is bad cholesterol. Non-HDL cholesterol is like all of the cholesterol particles that aren't good for you. And then in addition to that, your lipoprotein A, which is really important.
So why do you think providers aren't capturing this information?
I've been thinking about this and going back to history. This particle was discovered in 1963. But it took a long time for literature, right? Studies to come out for us to see, where is this going, and to do population level analyses to say, okay, there's correlation here, there's causation here. Even if your cholesterol is normal, having a high lipoprotein A leads to heart attacks, strokes, etc. More recently, there's been several trials underway because there was no treatment for it. People would check it and they say, okay, well, now what? Well, we have several potential treatment options coming on the horizon. There's actually one trial called the Horizon trial with pelacarsen to lower lipoprotein A by 80 to 90%. But the question is, by lowering it by up to 98%, does that lead to less heart events? The hypothesis is yes, but the outcome trial data is pending. Hopefully by this year.
That's
awesome.
exciting.
Really
Yeah.
exciting. So, how about our red flags? So, are there any red flags like your family history, age, symptoms, life stage where you immediately think, we need more than this?
Sure. In my clinic, when I evaluate patients, the first stop is family history. Tell me about mom and dad. Tell me about grandma. Did anyone have heart attacks or strokes early? I don't remember. Is sometimes okay. Well, why? Did you ask family members? And oftentimes people have had heart attacks or they didn't get to see their grandma or grandpa, right? And so that's oftentimes heart disease. And so that's one of the biggest red flags. For women, I ask them about, if they've had kids, how is their pregnancy journey? Did they have preeclampsia, gestational diabetes? Did they have hypertension during pregnancy? All of those are increased risk factors for women having cardiovascular disease. And so I almost go fishing for risk enhancers, right? So the family history, the pregnancy, taking a look at any pregnancy complications. And then overall, taking a look at where they are in terms of what their blood pressure is, where their cholesterol is today, and what their goals are.
And following down the thread of kind of investigations, ApoB is another test we can do. Is that more meaningful than the LDL alone? Is that something we should be doing?
Yes, and great point, right? So we've been checking LDL cholesterol, but when you get an output of LDL cholesterol, we've been calculating that from all the rest of the labs that you have. So it's not a direct measurement. In reality, ApoB is the marker we should be checking. This is your actual particle number. This is what is causing atherosclerosis, and it's a more accurate marker. But for years, we've just been using LDL, and that's very hard to change behavior, and that's just what we're using. But for my patients that have a family history, I really look at ApoB, I look at lipoprotein A, and I put them together.
I've noticed that in the metabolic risk panel that the ApoB is an automatic with the lipid panel and then a hemoglobin A1C, at least what I'm ordering at Quest. Is it wrong? Like I've been explaining it to patients as ApoB tells us how bad your bad cholesterol is. And then my second part of that question is, when the ApoB is greater than 90, at what point do you move on the LDL? Because I'm used to, if the LDL is greater than 170 with one comorbidity in women in midlife, treat, and then greater than 190 automatic treat with like a statin. So what are your thoughts on how I explain it? And at what point do you get concerned with the LDL when the ApoB is elevated, but maybe the LDL is like 120?
Yeah, sure. When there's a discrepancy, ApoB is one of the most accurate, so I use that. If there's a discrepancy between LDL and ApoB, I'm paying attention to what your lipoprotein A is, because sometimes that's included into your LDL, right? And so if that's what's causing a lot of your particles or your LDL to be elevated, then I'm much more aggressive in these folks. So depending on when we talk about lipoprotein A, going back to lipoprotein A, there's like two different assays. So let's say you go to a lab, right? You can either measure your mass, like how heavy the LPA particles are, or a particle number. The mass, anything greater than 50 is high risk. Anything greater than 30 is abnormal. When you're taking a look at particle size, which is more accurate, right? Greater than 125 is high risk. Between 75 to 125, you're in an elevated risk, but you're still high. I just think it's important for everyone to know that there are two different metrics depending on what lab you go to. We're trying to get a universal test trying to measure it in particle size. But I think it's important for folks to realize that there are two different assays out there, and those numbers, you just need to pay attention to the unit metrics because it's
It's a really good point because I think, we do that in so many other different types of lab tests that we do too. So even just for clinicians who are listening to this, can we go over just, real quickly that when they're ordering their ApoB or LP(a), which test they should be using?
Sure, absolutely. So when you're ordering your lipoprotein A, it's really depending on your lab. And oftentimes you don't know. You just click the button in your EHR software, and it comes back to you. But it's really important to pay attention to what metric you're using because if you just quickly Google search what's normal LPA little a levels, they may tell you the particle size instead of the mass size. So that's important. ApoB is just is regular. There's no different lab variations. And so in my patients that have an elevated lipoprotein A, depending on how high they are, but usually greater than 125, if they're measuring the particle size or greater than 50, I'm really trying to lower their ApoB level to, less than 60 sometimes, depending on their family history. All of this is like, when someone has an elevated lipoprotein A, again, that's a risk enhancer. If they have more comorbidities, it's just like, what are the ingredients to build up plaque, right? And if you have a high LDL, if you have a family history of early heart disease, if you're a smoker, a diabetic, it's just adding fuel to the fire by having a high lipoprotein A. And so I'm going to try to decrease their LDL and ApoB as much as I can.
Yeah. We see, it's interesting because, it was founded in the 1960s, but I don't remember being taught those things in medical school or residency. Really, it was like LDL, and those LDL guidelines have changed so many times in, the almost 20 years that I've been practicing in family medicine.
First, I always have a conversation with all my patients. It's not just about me throwing medications at them, right? It's describing what their risk is, and saying, okay, what are our treatment options? I can tell you that if I take anybody, there's a big focus on longevity, right? If we just take a look at the science, right, there's people that are born with genetic defects where their cholesterol just isn't high, right? So their LDL is less than 50 their entire lives. Well, guess what? They usually live into their 80s and 90s without heart events, right? And so if we chart someone with a normal cholesterol and their LDL cholesterol is over 100, if we can make that cholesterol, the bad LDL cholesterol around 50, most patients live to their 80s and 90s without heart disease, right? So if you prevent the ingredients of building up a plaque, right, throughout one's life, there's just less risk of heart disease and stroke. Now, that risk can never be zero, but if we can lower it, by lowering LDL cholesterol, one of the best treatment options that we have lots of trial evidences on is statin therapy, right? So my first go-to is statin therapy. Atorvastatin and rosuvastatin, those reduce your cholesterol by about 50% at high intensity doses. And so the less bad cholesterol you have floating around your bloodstream, the less stuff sticks onto your blood vessels, the less likely you are to have a heart attack or stroke moving forward. We have lots of other tools. Statins have had, bad publicity. I think when you take a look at all the trials, we're talking hundreds of thousands of patients, we realize that, statins decrease heart attacks, strokes, decrease the risk of vascular dementia. Are there side effects? Yes. Some folks have muscle aches and pains. Anecdotally, I'll tell you, a lot of patients say they're runners, they're really active, and I start them on a statin medication, and all of a sudden they have extreme muscle aches and pains that they just can't run, right? And so we know that myalgias are one of the side effects. Even though in the trial data it's a small percentage, in the real world, patients do complain of it, and there's other tools that we can use. There's non-statin medications like ezetimibe that decreases your cholesterol absorption from your gut. That reduces your LDL by about 15%. There's a new medication that came out called bempedoic acid that works upstream in your cholesterol pathway, similar to the statin medication, but it doesn't get into your muscle cells, and that also reduces your bad cholesterol by about 20%. And then finally, there's injectable medications called PCSK9 inhibitors. So they essentially cause more receptors on your cells to vacuum up the bad cholesterol, reduces your bad cholesterol by up to 60%. And that's an injectable that that you can give yourself twice a month. You take it home, you put it in your fridge, you inject yourself twice a month, and reduces your bad cholesterol by 60%. There's also a medication that you can get prescribed in clinic. Once you're loaded with this medication called inclisiran, you're able to come into your doctor's office every 6 months and get this cholesterol injection, and you lower your bad cholesterol by 60%. Now, the two injectable medications I talked about, the PCSK9 inhibitors and inclisiran, they also can reduce your lipoprotein A by about 25%. What does that mean? We still don't know. We have trial data coming out telling us with some of these newer medications that reduce it more, the effect of lowering your lipoprotein A. My belief is that if you're going to give a medication and your lipoprotein A is very high, and if your insurance company covers it, I'm going to reach for the PCSK9 inhibitor that's going to lower your LDL cholesterol by 60% and also lower your lipoprotein A by 25%. There are some trials in high risk patients. When patients did take PCSK9 inhibitors, the people that benefited the most were the folks at the highest risk with the highest lipoprotein A. It did reduce it. So there is a trend towards these medications to decrease the risk for cardiovascular disease in patients that are at high risk. And we're going to find out, the trial data is going to come out hopefully this year. It's going to first go to folks that have really high cholesterol levels, that have had heart attacks and strokes and high lipoprotein A levels. They'll be given that medication. The next cohort will be people that are high risk, high calcium scores, just high plaque burden, and high lipoprotein A scores. Can we prevent the first heart event, right, for these patients? So for my younger patients that are in their 30s, right, because 1 in 5 people have an elevated lipoprotein A, I tell them there's hope on the way, right? There's lots of medications, but between now and then, it's all about doing all the things: exercise, diet, and doing everything we can to reduce your bad cholesterol. Just less ingredients for plaque difference.
I have 3 follow-up questions from all of that. First one is, do we have any data on the percentage drop in lipoprotein(a) with bempedoic acid?
Great question. There is no trial that has definitively said that it drops LP(a). There was 1 or 2 trials that suggested it, but the follow-up trials didn't show it consistently. So bempedoic acid is not on the horizon. But PCSK9 inhibitors and Leqvio or inclisiran are the 2 medications that do reduce your lipoprotein A by up to 25%.
Yeah, that's such a shame about bempedoic acid. It looked so promising there for a while. We're a little confused in the menopause space. Do we have the same data for women that we do for men to say that starting a statin will decrease the incidence of your first heart attack or stroke?
When I take a look at men and women, so women are protected with estrogen, right, up until menopause. And then every 10 years later, every decade later, they quickly catch up in the risk of heart attacks. So, a woman at 60 is getting closer in terms of the percentage of risk for a heart attack. And by the time you get to 70, 80, that's your men and women are neck and neck, right? We all die from something. Heart disease is the number 1 cause of death. When we look, about why estrogen may protect women, I don't think estrogen isn't just a reproductive hormone. It's a vascular protection hormone. Before menopause, estrogen really keeps the blood vessels flexible and improves blood flow. It lowers inflammation and just makes cholesterol less dangerous. That's why women often really look low risk in their 30s or 40s, even when their genetic risks like lipoprotein A are sitting quietly underneath. Again, I think estrogen is what keeps the arteries soft, calm, and resistant to damage. And so once you're post-menopause, we start seeing that risk unfold very quickly.
And then the other thing you mentioned was when you start a patient on a statin, sometimes they'll have muscle aches and pains, or myalgias, as we call them. Do you ever use coenzyme Q or ubiquinol when you're starting a patient on a statin? Do you find those helpful at all?
The research would tell you no, but I have patients that come and they find out from a friend that, they have muscle aches and pains. They start taking it and the muscle aches go away. For patients that have been taking both at the same time, I say stop taking it. If you don't have muscle aches and pains, save your money. So in my experience, the science says no. Patients tell me differently. And I tell my patients if it works for them, great, go ahead. If it's going to keep you on the statin, lower your LDL, less chance of heart attack and stroke, go for it.
Yeah, the other thing I would mention to anyone listening is I often, when I ask the patient what dose they were started on, it's a high dose. Like someone just threw them on the middle dose of a statin. And I often find if we go back and start on a really low dose and work our way up, that we can avoid the myalgias then as well.
Absolutely, and sometimes you can get your best bang for your buck with starting with the low dose. So rosuvastatin or Crestor 5 or 10 milligrams, you really lower your protein B the most. You lower your LDL significantly, especially in my younger patients. Right, they're in their 30s, they have strong family history. I start them on 5 or 10, and I assess their response and see how they're doing with it. And you're exactly right. Sometimes hitting folks with the highest dose of that medication gives them those side effects, especially if they're never on a medication to begin with. And then when you start anything else, you're really hesitant to start it, right? So I think that conversation is really important.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Diving in a little bit more on the LP little a couple questions that I had for you. Is there a particular age where we should start to order this? Should it be at menopause? Should it be tested earlier? And then I had always been told it was a one and done test, and what you got was what you got, and it was never going to be different. And I had a patient recently who had premature ovarian insufficiency, so has been menopausal for 15 years. She's 48. And I don't know what I was thinking. Somehow or another, I ordered a second LP little a, and it went from 150 to 270 in 6 months. Her LDL is 112, and her ApoB was 150. And so I said, like, I think you should go see cardiology. I have a good family history of cardiac disease. And her primary is like, oh, you do all the right things. You're a vegan, you exercise, there's nothing for you to worry about. And I was like, okay, now what do I do with this?
Yeah, no, that's great. Usually, lipoprotein A is stable, after the age of 5, but there's variations, right? So the gene doesn't change, but the vascular environment does, right? So after menopause or perimenopause, so LPA often becomes more inflammatory and more dangerous, even if only the numbers rise modestly. So menopause doesn't change the gene, but it changes how loud the gene speaks. There's different times, especially for women. So during pregnancy, your lipoprotein A can go up by 2x, right? So I don't recommend checking lipoprotein A around pregnancy. And during menopause, we do check it, and there's a lot of variability on lipoprotein A. But if it's significantly elevated, I'm going to recheck it postmenopausally just to see where they end up. And so I don't think women that are approaching 50 or whenever you have, menopause, should be disregarded, right? You want to see what your risk is. And if your lipoprotein A is in the 99th percentile, okay, great. That uncovers risk. We should pay closer attention to you, do all of the testing that's necessary, but then revisit in a few years postmenopausal.
So anytime except pregnancy, you can check an initial and then repeat it.
Yes, so I think LPA should be checked at least once in adulthood when hormones are stable. So I would avoid it during pregnancy, during acute illnesses. I'd be cautious during perimenopause. Those are the states where I would be cautious.
Makes sense.
Yeah. So it's about also getting them their primaries to check it with their initial lipid, right? Because really in primary care, we should be doing those at 18. And then again, depending on those levels and, in early adulthood or every, 4 years, depending on if their labs are normal. So I can't tell you that anybody I have seen has ever had one.
It almost sounds like it's an inflammatory marker, doesn't it?
With saying that right. Yeah.
And it is. It's pro-inflammatory, pro-atherosclerotic, right? And so exactly as you say, especially this younger generation, right? We're all wearing the Aura rings and we're all data centric, right? And we're uploading everything up to ChatGPT. It's everyone wants knowledge, right?
I love that
And
you called us the younger generation.
We love that.
if you're just armed with knowledge at age 18 that like, hey, I'm at high risk, then that stays with you, right? Then you can act on that and you can check in more frequently with your physician or your clinical provider. And that allows you to engage with healthcare a little bit more, get more information when you need. And that's where knowledge is power. Having that information is going to change your behavior, and that may lead to just better lifestyle, perhaps you getting on a medication and preventing that first heart attack or stroke so you could live longer or have another year without, a heart disease or a stroke, etc.
Do you have a level at which you, of the Lp(a) that you're like, okay, I'm going to start a PCSK9 inhibitor. It's going to get covered, and that might be two separate questions. At what level are you like? Do you bypass the statin? Are you starting a statin first and then going to that? And then can we just touch on just coverage?
Sure, absolutely. This is where it becomes murky, right? So PCSK9 inhibitors have been out for 10 plus years. The data is excellent. It lowers your LDL by up to 60%. There's a lot of it's easier to give yourself a shot twice a month instead of take a pill every single day. And so I just have a discussion with my patients about what they prefer, right? And there's out-of-pocket costs for some of this stuff as well. It all depends on where you are. Most insurance companies will want you to start a statin first in this era. I've tried to just send off PCSK9 inhibitors, and for my patients, the copays are just too high or the out-of-pocket costs are too high, and then I start with the statin medication. I would say if I had any tool, if someone comes to me with an LPA in the 90 plus percentile, LDL is also high. That's my first tool that I would reach for in terms of just efficacy, safety, and what I'm seeing on the ground. Statins are great. They lower LDL by up to 50% at high intensity doses, but they can also increase your lipoprotein A by up to 25%. And we don't know what that means yet, but we know that lowering the LDL leads to significant reductions in your cardiovascular events, and those benefits outweigh the cons of maybe the variability in increasing your lipoprotein A. All of this is something we're still trying to figure out. Every person's a little bit different.
Wow, that's so interesting. I didn't know it
Mhm.
increased your lipoprotein.
Yeah, that's really interesting.
We
Well,
were
that's
we
just
mentioned
Peter to pay.
we mentioned inflammatory markers there. Do you check high sensitivity CRPs on your patients? Should we be checking them?
Absolutely. I think if you're, I think so. High sensitivity CRP is a marker of inflammation. Inflammation is bad for blood vessels. It leads to heart attacks and strokes. And so if you have a high lipoprotein A with a high sensitivity CRP, that is just, again, adding fuel to the fire. And those are the patients that are going to have aggressive plaque formation. And so it is good to unlock those. And oftentimes when I see a high elevated lipoprotein A, I'm ensuring that I have at least checked the high sensitivity CRP at least once.
And when you recheck the lipo(a) after using the PCSK9 inhibitor, how long should clinicians wait to recheck that? Or do you recheck it? Because it does decrease it. So is that something that we need to be following or they should be following?
Yeah, no, this is great, right? So the recommendations are to check it once, but once we have therapies that actually reduce it, and then folks want to know my LPA
Right.
is a little high, I lost sleep over this. Where is it now after I
Yeah.
had my PCSK9 or one of the new medications that folks could start? So I think we're going to go from check it once, those that are really elevated, to checking again to see where you are. Usually I check it anywhere 6 to 8 weeks after starting, sometimes a little bit longer. So it's hard to see follow-ups. I think throughout nationally, we're seeing a shortage of physicians, and so it takes longer. So oftentimes I don't get to see my patients again until 2, 3 months. And so I'm checking it again right before. And it's great. The patients that have like sky high lipoprotein A levels, oftentimes instead of a 25% reduction, I'm seeing, sometimes up to a 50% reduction. So people at the highest levels actually benefit the most from it. Some people have it really doesn't move the needle, and others it moves it. Again, this is all new. We're all figuring it out as we go, and so I'm really excited for the trial data that's coming up. And there's several more medications and several other drug companies that are releasing their data in the years to come. So it's going to be an exciting space.
I have been doing, lipoprotein testing on my patients, but, as we all have seen in, perimenopause into menopause, there's so much mischief with, women's metabolic flexibility, cholesterol, the good cholesterol goes down, the bad cholesterol goes up. And now, we add in APOB and we add in LP little a. I mean, is there a period of time where, getting women's hormones, especially you figure some of the older women that, haven't been maybe are 5 to 10 years out from hormone therapy because, they missed the window when we weren't talking about hormones, to get them in a better place hormonally and then reevaluate before sending to cardiology? And then does it also open the conversation or maybe help with the insurance justification, since many of them, have weight gain, about GLP-1s reducing, and trying to reduce that inflammation and then reevaluating in like a year before sending to cardiology, since the primaries are a bit confused what to do when I send them back.
Yeah, no, absolutely. That's great. I think when your body's in flux, you're gaining weight, inflammatory markers are up. I think there's a lot that clinicians can do when they first see a patient. GLP-1 medications, the data that's coming out is all positive, right? I'm very cautiously optimistic, but if you lose weight, you decrease your CRP, you decrease inflammation, metabolic profiles get better, LDL gets better to an extent, right? So diabetics get off their medication, so you're really changing around someone's entire cardiometabolic profile, and it's a little bit different, right? And so the patients with an elevated lipoprotein A that have all of these other things that are kind of adding fuel to the fire of diabetes, the family history. I've put a lot of patients on these GLP-1 agonists, and they've turned their lives around completely, right? Medications go away, blood pressure medications they come off blood pressure medications, they come off diabetes medications. They're going to the gym. I always tell my patients, both men and women, to really exercise on the GLP-1 medications because, if you're 200 pounds, if I put you on Zepbound or Zepbound, you'll lose about 40 pounds, but you're going to lose a lot of muscle. It's not like you're exercising on a treadmill where you're preserving some muscle mass. So it's really, really important for patients to exercise and do resistance training at least 2 to 3 times a week when when they're on these medications. So to answer your question, yes, when you're in this flux state and your inflammatory markers are up, just during menopause, your estrogen declines, your protection stops sometimes really quickly, your blood vessels are stiffening, your cholesterol again is worsening, inflammation's rising, and that's an opportunity for some of that plaque, if it's there, to become unstable. So I don't think menopause doesn't really cause heart disease. It unmasks it, and it's a tide going out and revealing the rocks underneath, so to speak. And so yeah, I think it's an opportune time for clinicians to act. And that's, when we're approaching, whatever, 45, 50, everyone does their 10-year evaluation. And that's oftentimes when I see patients. And by checking some of these risk enhancing markers, we say, okay, everything looks okay for now, but you're at high risk. You're going to come and see me, every year, and we'll reevaluate because, risk is, these risk enhancers are our guide for us. We're not there yet with precision medicine where we know the exact patient who's going to get that heart attack or stroke, but we can say, okay, well, from 100 people, now we're focusing on our top 20 maybe that we need to pay attention to really affect lives.
We talked about some of the meds that can drop the lipoprotein little a, but we saw in the Women's Health Initiative study that estrogen can do it. Is there any talk within the cardiology profession about how using estrogen to actually decrease lipoprotein, like as a treatment?
Yeah,
Probably you'd use it in menopausal women, right?
Yeah, so I think women have been done an injustice. For years, we've been saying no hormone replacement therapy, and the symptoms and the misery that they've gone through for data that was from the women's heart study. The women were 63, right? And so it was a different population, and we kind of generalized. I don't think hormone replacement therapy is a magic shield, and it's not the villain it was made out to be either. When started early, around the time of menopause, it's in the right patient, it can restore some of estrogen's vascular protection. I think it really helps healthy arteries stay healthy. In terms of lipoprotein A, I haven't seen any good data to suggest that giving lipoprotein A is a treatment option for giving estrogen is a treatment option for them, but I'm sure more and more data will come out as we continue to relook at this. I think of HRT as a support for repair.
Yeah, and the key is to start it early
Yeah.
and not wait too long. You can
And it,
reverse that damage.
and to have it part of that, I think just that conversation, right? Where are you in this menopause transition when we're seeing patients and we're working them up cardiovascularly for their risk? It just really needs to be part of the conversation. And I think we just need to make sure that clinicians are assessing where that perimenopause and menopause transition is occurring in their patients when they're doing those risk assessments.
Mm.
Absolutely.
Part of the risk assessment a subject that often comes up is the coronary artery calcium scan.
Yeah.
Would you mind talking to us a little bit about that? I'm sure our listeners would love to learn more about it.
Sure, absolutely. So as we talked about, your blood vessels are like, yeah, actually, I tell my patients, I am here in Poughkeepsie, New York, and we have a lot of trades folks that come into the office, and so I simply put your heart's a pump, and you have three pipes that feed it blood, oxygen, nutrients, etc. If you cut those pipes in half, there's soot that builds up along those pipes, right? And over time, that soot calcifies, and that's cholesterol and plaque. And so the calcium score is a way of just taking a quick picture by CT scan to see how much plaque or soot that you have building up compared to everyone else your age and gender. Oftentimes, it takes plaque a little bit of time to develop, right, and harden. And so usually that's in your 40s or 50s. If you have a family history of early heart disease, that may start happening in your 20s and 30s. And so I tell my patients, depending on when you're coming in for a preventive evaluation, I am a strong advocate for getting a calcium score because it gives me a baseline to see where is it that you're starting to build up plaque. Are you at 0, right, which is no plaque, or are you in the 75th percentile? And oftentimes, it also helps with the adherence. So if you're 40 years old or 45 years old and you're not on any medication, and all of a sudden you get some testing that shows you the plaque, seeing is believing. And so oftentimes when I show my patients and I pull up their plaque on the screen, it becomes real. And then
Mhm.
the medication becomes a real conversation. Adherence improves,
Mhm.
right? And so I think the calcium score is really important. Unfortunately, insurance doesn't cover it, but across the country, most folks have been offering this for about 150 bucks out of pocket. You go through, I had mine about a year ago. You pay 100 bucks, you get the scan. It takes about 10 minutes, and then you have a risk assessment. It's great for taking a look at how much plaque you have. Now it tells you, depending on the report, it'll tell you how much plaque you have in certain vessels, what's your total plaque burden volume, and it also gives you just where you are compared to everyone else your age and gender, so you can see how aggressive you need to be. And that and on top of so this is again, all the blood tests are risk enhancers, and then when I get the calcium score, this is actually what's happening. That's biology in action, and this is what we're seeing, right? And so if I see those two together, I'm very, very aggressive in getting folks LDL as low as possible. If their calcium score is elevated, they're in the 75th percentile, along with those risk enhancing factors we talked.
And I mean, if the coronary calcium score is 0 and the LP little a is elevated, at the high risk category, does that change your management or not?
To me, I know from data that high lipoprotein A, if it's again greater than 125 nanomoles per liter, I'm going to be aggressive. I'm going to have that conversation. And I tell them, if you were my family member, I would start you on a cholesterol lowering medication. Whether you do it today, this, next year, at some point, we're going to see each other. We're going to have that same conversation. And at some point, it's just having that conversation, knowing that your doctor is telling you this information, that allows patients to then go home, do their research, talk to ChatGPT. And oftentimes they'll give me a message back like, yes, let's start it, right? Or let's start at low dose. Or let's start it every other day and see how my body responds to it, see where my cholesterol and stuff is. So I think all of these, the calcium score of 0 gives you a lot of, it gives you confidence that your 10-year risk may be low. However, if your lipoprotein A is high and you're a diabetic, there is recommendations to maybe, reassess in 3 years to see what your calcium score is, right? Because plaque starts to build up pretty quickly. So my patients that are high risk, I often, and if they're not diabetic, with the high lipoprotein A, I'll repeat the calcium score in 5 years if they want to, right? I have to be mindful, right? $100 is a lot of money for some folks. And so if they're struggling, we just talk about what the treatment options are. If folks want to know their data, the younger generation does, they'll get a repeat scan just to see where they are.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com. And so these scans we talked about show calcified plaque, but not soft plaque, which tend to be more problematic in women and cannot be seen on these scans. So how do you account for that limitation just in the overall clinical plan?
Right. So if your calcium score is 0 and you have chest pain, that still needs investigation, because we know that a small percentage of patients that have chest pain, even with a calcium score of 0, are still at risk for a heart attack. Soft plaque is something that I'm so excited about over the next few years. So there's something called cardiac CTA. So if you're having chest pain right now, one of the main things that you can get is a coronary CTA scan. So it's a CT scan that does the same thing as a calcium score would, but you get contrast dye and we can see the blood vessels of your heart. You can see the hard plaque and you can also see the soft plaque. Depending on the software, the quality of the study, et cetera. And we're moving into an era where with AI, we're able to quantify the total plaque burden. We're able to tell you, is it soft plaque? And from that soft plaque, there's some soft plaque that's unstable, almost like a volcano about to erupt, okay? And so we can identify that in 2026, right, for a lot of people. And you go from having a high calcium score to maybe a CT scan of your coronary arteries that tell you where that inflamed artery is, right? Where that plaque is that's really concerning. And that just changes your management into how aggressive you may be, because you now have a lens into their future, because we know that some of these soft plaques, a lot of these soft plaques are the most unstable. And those are the ones that are going to cause heart attacks.
Do you think that will replace the coronary calcium score at some point?
I think it's a more advanced test. I do think that we're moving to a CTA first approach slowly, especially with value-based care, right? If someone comes in with chest pain in the emergency department, you know right away, how much plaque there is, if there is any plaque, where that plaque is, and then how dangerous is that plaque. And so I do think it's a more advanced test. There is some concern about radiation, especially in women with breast tissue. It's something we need to be mindful of. I don't think everybody needs this scan yearly, right? But it tells you a lot of information in a like data centric world. I think it's going to become more and more used. The amount of radiation has improved significantly over time. So I'm very hopeful. I'm a digital healthcare optimist. I'm a CTA optimist. So I think this is the wave of the future. I'm so excited for it.
Yeah, that's exciting.
So at what point would you recommend, like, when do you want clinicians to refer to you? Who's your ideal patient that you're like, I wish they had sent you here 5 years ago? Who should we be sending to you where you know all of these nuances? Just like we want people to send their menopause patients to us because we know the nuances, right? So who's your ideal patient?
And so as a preventive cardiologist, I spend a lot of time thinking about this because, all of our clinicians are so overburdened, right? So for my first thought is to get to the highest risk people, right? So the folks with family histories with high lipoprotein A greater than 125. If anyone has an LDL cholesterol greater than 190, that's a concern for familial hypercholesterolemia, they should really see a preventive cardiologist. So getting to those highest risk folks, and then there's different tranches of folks that, 160 to 190 family history. Again, seeing a preventive cardiologist when you have a strong family history or high lipoprotein A, I think is always a good idea. But I would start with the highest risk folks first, especially if you have anyone that tells me that they have a family history of mom or dad that have had an MI in their 30s, 40s, or even early 50s, is folks that I want to see because I want to prevent that for them and their family.
And I suppose still on the risk thread, in primary care, we use calculators sometimes to help a patient while we're in the exam room with them, because in general, we do like to ignore these things, you know. And so I feel like
Right.
when you go through a calculator with a patient and they see you plugging in the numbers and you're looking at this big picture, it can really, like you said, when they see the result of the coronary artery calcium scan, it can really make things real. I find that with the calculators as well. Do you use that at all in your practice? Do you have one you prefer?
Yeah, so there's so many calculators. We only have so much time with patients. Oftentimes, by the time they get to me, the clinicians have already said that they're at increased risk. There's something called the prevent score. Again, that'll just tell you. Again, there's different flavors of these calculations that just tell you how high of a risk is, and it's almost a translator to folks. You're at 10% risk, 15% risk. Once I start getting more data back, like the calcium score, and I have the cholesterol, if someone is really struggling with a decision to start cholesterol lowering treatment, I think it's a great option to plug in this information into whatever calculator that you see fit, to use that as a translation tool to say, here's your risk and here's where I see you. And on this medication, your risk is lowered 5, 10, 15%. Right. And it's just, I think empowering patients with that knowledge is really important.
Yeah, it's a good tool.
So, we know women are getting a lot of their information from social media. What have you seen on TikTok or Instagram, if you're over there, that you find is accurate? And where do you see confusion in what patients are hearing that does not meet the mark?
That's a great question. So I I love that social media has made people curious about their health, but the algorithms are really built for anxiety, not accuracy. So, like a 15-second video can tell you to worry. It can't tell you what matters for you. So, if someone is selling like a cure-all supplement in their bio, that's marketing, right? That's not medicine. So, I think social media is great at raising questions and terrible at giving answers. Like I find myself on social media and I'm scrolling through reels and I'm like, everything causes cancer. I can't eat anything, right? Like everything has microplastics in it. My coffee cup, everywhere I turn, it's just more anxiety. But like, I think I think you need to take everything with a grain of salt. And then when folks come to me, I have to just explain and translate and just almost calm their anxiety. They've spoken with someone. So I think social media is great at getting knowledge out there, but I think a lot of folks are in this attention economy are just fighting for attention. And what's better than getting everybody worried, right? And so I have a little bit of reservations when folks try to sell people on this, and so that's my only worry. I think again, online, people worry about some of these obscure toxins or microplastics. And I do think that we should be worried about what we're putting into our bodies. I think nutrition science is lacking, and there's a lot of things that we don't know yet and that we should dig deeper on. But in clinic, I'm worrying about blood pressure, cholesterol, the silent plaque, right? I see people that have had heart attacks in their 40s or 50s that felt completely fine the day before. Right. So feeling good is not the same as being low risk. And so, to answer your question, I love social media. I think it's great to get information out there. I get a little bit worried about some of the stuff that's garnering the most attention because sometimes that's not the most practical for patients.
Yeah, it's really hard to make sure that you guide them toward the practitioners who are evidence based and really trying to give as much appropriate education out there because there's so much other noise out there. That's what I struggle with some of my patients as well. Yeah, I have one last question before we wrap up here a lot of us have patients and probably more so now that maybe are outside that 10-year window of menopause, but they're still having hot flashes. They have osteopenia, but we are concerned about their cardiac risk. So, should we be a lot of us we're checking their lipids, do we do a coronary calcium score, or do we have them see a cardiologist? And do we need to make sure that we have them see either a preventative cardiologist or someone that also understands the benefit of estrogen, and have them see a cardiologist in addition to helping us in order to make that decision on the risk benefit for putting them on like a transdermal low dose patch to help with their hot flashes and to help protect their bones.
Absolutely. I do think that a lot of folks would benefit significantly from seeing a preventive cardiologist, right? This is the stuff that I'm reading on nights and weekends, right? This is stuff that interests me. And it's just a different space, right? And I look at things differently, and I'm trying to unmask risk and prevent heart disease. And every clinician has their own interest, right? And so I do think, going to a preventive cardiologist that's interested in taking a look at these things. And then also just keeping patients, seeing them every year, and things change, new medications come out, right? And that's when you can really intervene when you're there. I guess my question for you, all of you guys, would be, what do you want cardiologists to do more of? And when should we be referring to you guys?
I'd love cardiologists to know more about hormone therapy than I think is taught in residency and fellowship, because I think when any specialty is taught about it, it's taught as HRT, HRT, HRT. But that in cardiology terms would be like saying antihypertensives, antihypertensives. Beta blockers have completely different actions and side effects and benefits than calcium channel blockers and diuretics. They're completely different. And that is the same for us when it comes to hormones. Estradiol is completely different to combined equine estrogen. Medroxyprogesterone acetate is completely different to micronized progesterone. And so that is not taught. And estradiol, for instance, does not seem to have the same effect on macrophages and matrix metalloproteinase that combined equine estrogen does. And so when I see my patients coming back from cardiology, they'll often have a, no, we don't advise this. And I see patients with SCAD as well, spontaneous coronary artery dissection, which happens a lot across perimenopause, unfortunately. And it's always HRT, HRT, but it's so nuanced. It is precision medicine, and we're not taught it.
Absolutely. I couldn't agree with you more. I didn't learn enough about it in med school. Things change with time, and there's just so much coming at us. I think that the cardiology community could definitely do a better job at this, and we're rethinking all of this, right? But it's just making this standard of care. And I applaud you guys for getting out the information, because this is what we need, right? Knowledge is power.
We are available for the cardiology conferences.
Yes, we're always.
Aoife's at an unfair advantage because she's like a walking encyclopedia,
Oh my
because
gosh,
she went through
yes.
2 residencies because one wasn't enough.
You're my go-to.
Yes, we love
Oh.
partnering with our specialists, because half of our battle is trying to, risk assess with our patients who are they're scared. And so, when we can partner with our colleagues, I think we're just so much more powerful. And I think this day and age in medicine, it's a team approach, right? One person just can't do it anymore. There's just so much specialty going on, which is great. But I often will see, and I think those patients benefit from having a team around them. I think that's going to be more toward the future. We're going to see more and more of that, I think, and hope.
And I think too that menopause practitioners are particularly good partners with cardiology, because often just women want to be on hormone therapy so badly that because they want to feel better, and they realize that they don't want to, be the one person that they think of that is living in a nursing home, can't remember her name or can't move. And I find that it's enough to move the needle for them to go on that statin and take care of that cholesterol when you start talking to them about, I have no problem with if you're, 65 and you're miserable and it's been 10 years, I don't have a problem putting them on a transdermal, but I really want them on a statin to stabilize whatever heart plaques we have going on. So I think it's a really important connection. And it's probably the number one thing that in our space, people are really uneasy about, a little bit confused. And a lot of patients get gaslit because the providers are like, absolutely no, when really it could be a great partnership to get to yes, where the patient gets what she wants and we help her live for as long as she's going to live.
And I think just taking the stigma off of statins for women, because for so long, women thought, it really didn't decrease their mortality and morbidity like it did for men. And at the last menopause conference, they did really touch a lot on that now those studies are out and it's the same. And so when I'm educating women on that, they're surprised. So I think we also need to kind of push that education that we do have the data to support that.
Dr. Intwala, do you have for our listeners to wrap up one thing or one message that you want them to take away from today's episode?
A few things, right? So estrogen kind of masks your risks and menopause really reveals it. And HRT may soften the landing, but it doesn't appear to erase the genetics. LPA is dangerous because it's sticky, it's inflammatory, and it's pro-clotting. And the most dangerous number is the one that you don't know. Heart disease is predictable, and that's a good news because predictable means preventable.
Fantastic.
Oh my gosh. Thank you so much for taking time out of your day to be with us today. So we know you're so busy, but this is so, so important, especially during, what better of a time of the year or February and coming up to Valentine's Day here coming up pretty soon. So just thank you. Thank you. Thank you. We really appreciate what you do. And our listeners are going to get quite a bit from this. Have a great night. And we make sure that you follow us, like, subscribe, follow us on all of our social platforms. We will put all the links in the show notes and we will see you all next time.